Allie, can you? Oh, they are? Okay. Am I on? Okay. Hi, everybody. Welcome. Thank you for joining us tonight. My name is Robert Levitt. If anyone doesn't know, I'm the acting dean of the Daniels faculty. So tonight's event is the annual Zeidler-Evans lecture, which is this year entitled Designing for Older Persons in a Transforming World. But before I begin with the introductions, I'd like to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on the land. As many of you may know, the name of the avenue on which the faculty sits, Spadina, comes from the Anishinaabe and means a place on a hill. The site was also part of an important trail for several First Nations, and as an institution committed to promoting truth and reconciliation, we note this history, and we wish to honor these connections as we move forward together. Okay, so on to the event. The annual Zeidler-Evans Lecture is a yearly sponsored focus on architecture and of health. It honors Dr. John Evans, who is the 9th president of the University of Toronto and the first dean of McMaster University's School of Medicine, as well as his dear friend, renowned architect Eberhard Zeidler. Between 1967 and 1972, Zeidler and Evans collaborated on McMaster's Health Sciences Center, revolutionizing both hospital design and education in the process. Zeidler served as an adjunct professor here at the Daniels faculty from 1983 to 1995 and established the Eberhard Zeidler Scholarship with his wife Jane in 1999. The Eberhard Zeidler Library, housing 37 volumes, underneath of the rake seating behind at the back of the theater here, is also named in his honor. In keeping with these legacies, or their legacies, the lecture named for both men seeks to address complex health and design challenges and the goal of building stronger and more inclusive societies here in Canada and beyond. So to this end, the subject of this evening's presentation is designing for older persons in a transforming world. By 2050, the global population, age 65 and older, is projected to nearly double. While many older persons will experience relatively good health and longer lives, others, by contrast, will be at higher risk of becoming unhoused, experiencing mental and cognitive disorders, and succumbing to comorbidities. Resilient architectural responses are consequently needed to anticipate the needs and aspirations of this cohort, particularly against the backdrop of the global climate crisis. So, discussing these responses tonight are three distinguished authorities in the subject: Diana Anderson, Molly Chan, and our own Stephen Verderber. Dr. Diana Anderson is a triple-boarded professional, a healthcare architect, an internist, and a geriatrician. She earned her MD from the University of Toronto, and as a architect, you coined that word, yes? Good. It's a very good title. Has pioneered a collaborative evidence-based model for approaching healthcare from the medicine and architecture fields simultaneously. Diana is currently an assistant professor of neurology at Boston University and a recipient of an Alzheimer's Association Clinician Scientist Fellowship. She is also a healthcare principal at Jacobs, contributing her thought leadership at the intersection of design and health. Molly Chan is a principal at the Vancouver-based architecture firm NSDA Architects. A 6-time recipient of the BC Lieutenant Governor's Award, NSDA focuses on a wide range of project types including healthcare, special needs, social purpose housing, affordable rental and multifamily residential. housing. Among their projects are YWCA Housing for Women and Children, a Salvation Army, Harbor Light Faculty, and the Foxglove Supported Housing and Shelter. And last but not least, Dr. Stephen Verderber is a professor of architecture here at the Daniels, as well as the director of our Center for Design and Health Innovation. He's also an adjunct professor in the Dalla Lana School of Public Health here at the U of T. Stephen is a registered architect in the US, the co-founder of R2Arc, and the author or co-author of 9 books. His first book, Healthcare Architecture in the Era of Radical Transformation, published in 2000, has become a standard reference in the field. So Stephen will be, after the presentations tonight, we'll be conducting a conversation with our 2 guests. So without further ado, let me invite the first speaker up, Diana Anderson, and join me in welcoming all 3. Thank you.
Good evening, everyone. Thank you so much for coming out to listen to our lecture tonight. I'll start by making the statement that the impact of the built environment on our health, our minds, and our behavior is truly immense. And for most of us here in North America, we spend about 90% of our time in buildings, probably more if you live in a long-term care setting. And these spaces exert very strong and subtle influences on the way our brains function. Architecture can make you nervous, sad, distracted, tired, or it can make you happy and highly efficient. Architecture affects our emotional state, our physical well-being, and even our cognitive abilities. And it's becoming very evident that architecture can have a measurable impact. And I should maybe just note under my name, I have some disclosures. I do receive funding from the Alzheimer's Association, from Mass General Brigham, and from the Greenwald Foundation for some of my research. My contributions to the architectural field for aging are maybe not typical. I tend to focus on pioneering data in our design, and I'm trying to shift our profession over towards an empirical practice, the way medicine, law, nursing, bioethics have all shifted in recent years. And I do this through developing building codes and standards, conducting primary research, and also affecting policies, convincing politicians that spaces have an impact on our health. So I try to publish and speak at various venues and in various journals, as you can see on the screen, in both medicine and architecture. And I've noticed that there's often a gap between the design intent and then the eventual user experience in a building. And the Docatech model is really meant to try to close that gap by 1, incorporating evidence where we can, 2, making sure we have stakeholder inclusivity. We talk to people who live in these facilities. And we add a layer of bioethical inquiry. I did a fellowship in bioethics, so I'll sort of pepper the talk with a few questions maybe we can think about. So in 1984, that was really the year where evidence-based design as a field began. There was a study, very famous now, that was done. It was a small paper, 2 groups of patients who were in hospital. They'd had surgery. One group had a hospital room with a window that looked at a park. The other had a window that looked at a brick wall. The patients who looked at nature went home sooner and took fewer doses of pain medication. And so you can correlate this to cost as well. So now we're decades later, and we have thousands of these types of studies. So whether you're admitted to a hospital or nursing home and become confused and delirious, or you sustain a fall and an injury, or you catch an infection like COVID, or you suffer from a medication error, all of these have a relationship back to the architecture and the built environment. Everything from the lighting, the acoustics, even the sink placements. And so the following questions: how a building functions, how it stands up, what it looks like. These are all central concerns to us as architects. I see a lot of students in the audience. But I want to push us to think one step further. Let's ask the question, what does a building for aging do? For whom does it do it for? And in what way can it do it? If we know that certain design techniques or spaces can cause harm or benefit, do we have a responsibility as architects and decision makers to inform our clients or eventual users of the space of this data? So through the following few examples, I'll show you some clinical papers with results that I think you'll find interesting. And what I want to convince you of tonight in just a few minutes is that a hospital or a nursing home is a medical intervention. The building has that much impact on people who work and live there, just as much as whether they were to take a pill or have a surgical procedure. So this first paper that you see is a good one to illustrate the spatial scales. So every decision matters. This showed that there are outcomes that are affected in terms of health from the building form, the overall form on the site, all the way to different layouts within, to different material choices, lighting, nature, even music. This is some data obtained in Canada in 2020 during the height of COVID-19. This is CBC data, so obtained by the media, so it's raw data. It has not been analyzed. But it was enough, I think, for people to sit up and say, wow, look what's going on. This really demonstrates the differential impact of COVID-19 when it comes to buildings. So what it's essentially showing is that if you were living in an older nursing home model in Canada, one that was grandfathered in with older codes and standards, your chance of death was nearly doubled compared to if you were in a newer facility. This is a great study from McGill University, which quantified what we all sort of know intuitively. So these researchers found that for every additional meter you have to walk to wash your hands if you're a healthcare provider, the chance of you actually doing it go down by 10%. You can say, so what? That's pretty obvious. But I have found if you don't take these types of quantitative metrics with you to clients, to decision makers, then really you can't substantiate your design choices. We see the term design equity now in the literature and in the popular press. I think this paper really illustrates the concept the best. This is a critical care unit in New York City, and I'm sort of branching out from long-term care a little bit. You know, older adults are across many different spaces, but you can see that it's a typical racetrack model with a centralized staff station and patient rooms all around. One of my colleagues was a physician who worked here, and he started to notice that patients who were in the corner rooms were dying more often. And he wanted to know if the architecture was contributing. So he did a study and published it in a reputable medical journal. And he found that, yes, if you were admitted to this unit and you were sicker on admission, your chance of dying in hospital was higher if you were put into a corner room, which he termed a low visibility room. So maybe I'll put it another way that makes it easier to interpret. If you're admitted to this unit, you're critically ill, you would hope and expect that the staff members who are treating you would treat you equally to any other patient. And maybe true, you'll get the same care from any staff member, but what if the four walls around you are not providing an equal opportunity for you to heal compared to the person next to you? We talk a lot about beds when it comes to hospitals, when it comes to long-term care. Everything is a bed metric. I'm going to try to get us away from that language. Beds are not good. We tend to use the bed as a focal point in our designs. We put the bed in the center of the floor plan, and we design the room around it. Does this contribute inadvertently to inactivity? Sure it does. Can we design for mobility and not for bed rest? This doctor on the screen you see his quote. Dr. Morton Creditor wrote a fantastic paper in the early 90s called The Hazards of Hospitalization for Older Adults. And he flat out says in the paper, there's no therapeutic value of bed rest. In fact, he gives this diagram, and I've redrawn it for the slide, but if you put an older person in bed, this cascade takes just a number of hours, not days and not weeks. Somebody will come into the hospital with something we can treat, a pneumonia, a urinary tract infection, but they will end up going to nursing home, too decompensated to walk even. It's not the actual disease entity that did that, it's the bed rest. There's some interesting isolation studies in the 1970s done, I think in Montreal, social isolation studies. They took healthy young volunteers in their 20s and 30s and basically strapped them to a bed and took away all sensory input, radio, TV, human contact, nothing. They found that these people started to have sensory disturbances, things like hallucinations, in just over 2 hours. We do this to older people all the time in nursing homes and hospitals. That's what we do. So I work in the field of memory care with persons living with dementia. And as you may know, we do not have good pharmacologic treatments for dementia. We have some new drugs in the United States, but we're always looking for non-pharmacologic ways to deal with the symptoms of dementia. That's our first go-to. Something that happens as people dement in the course of their illness is they tend to eat and drink less. This can cause distress to families, and in medicine we've done things such as appetite stimulants, feeding tube insertions. We know now that these can cause lots of side effects and many harms, so we look for other ways. This is a pretty simple way and pretty neat. This nursing home simply took the tableware in their dining room and threw out all the white plates and white mugs and swapped it out for high-contrast red tableware. And look at this, 8 of 9 people ate and drank more, 25% more food, 84% more liquid, just based on the color of the table setting. Falls. Falls is a huge topic, right? A huge amount of morbidity and mortality and a huge cost to society. This study took 2 nursing homes. It's a fairly recent study. It's called some colleagues in Boston, and they took away all the light bulbs in one home. They unscrewed all the bulbs, and they bought new light bulbs. So you can imagine the cost is not that high to do that. And what they were trying to do is increase short wavelengths during the day, so increase our blue light, and then decrease that overnight, understanding the science behind circadian rhythms. They looked at over 750 people. They found that falls were reduced with the better light bulbs by 43%. And I'm going to pause for dramatic effect. 43%. So we do a lot to reduce falls. We use alarms, we use cameras, we use robotic-assisted fall prevention devices that cost a fortune, and we don't even get close to this number. This is really impressive. For every fall someone sustains in the US in hospital, it's over $60,000, over $23,000 if it's a long-term care fall. So knowing this and having access to this data, do we have a responsibility to go into all the existing nursing homes and consider swapping out the bulbs? How do we get this information into our minimum codes and guidelines? I think the challenge is architects and others who may write these documents don't always have access to some of this information and data. There's also one area in long-term care that has fairly robust data, and I think my colleagues will also mention some of this, but the household model. And some of you may know about this. It's gained a lot of traction since COVID-19. And I'm not really speaking about the greenhouse model or the butterfly model in particular. This is simply the idea of a smaller scale home for older adults, anywhere from 8 to 12 single rooms with private bathrooms, smaller decentralized living areas, and access to nature. We see huge benefits in the literature, right? Quality of life for one, but hospital admissions, less staff turnover, that's a big one that's being talked about, and the costs are not higher. So we have good data on that as well. And infection control, the data is just extremely clear. So this is showing 3 different circumstances around COVID. So column A is COVID-19 cases in nursing homes, column B is COVID-19 admissions to hospital, and C are deaths. And you can see the dark purple bar, or maybe you can't, because this is the household model. Almost no COVID cases, pretty much no COVID admissions, and no deaths, compared to traditional nursing homes of either less than 50 beds or 50 beds and more. This is some work I'm doing with some funding from the Alzheimer's Association across multiple years, and I'm looking at older adults in the community with and without dementia, because people with dementia are not really in nursing homes and memory units. Not many of them anyway are living in dementia villages. They're in our community. They live at home, cared for by family members and loved ones. So I want to figure out whether these spaces in our communities and our homes themselves actually can impact our health outcomes. So this is just some preliminary data. We still have to do a bunch more analysis. But what we're looking at here are window view types and window view frequency. And what I was trying to get at is in social determinants of health, in the clinic setting, we write prescriptions for exercise. We write prescriptions for diet. What if we could write prescriptions for how to use your space at home? Everyone has a window and access to one, so maybe we could counsel patients on using their space to benefit them. And the other aspect I think is important is the dark and light blue are cognitively impaired older persons and healthy older persons. We can enroll patients with dementia in research, and we should. We don't do it enough, but we can certainly ask them questions and study what they would like and what kind of scenario they'd like to live in. And in fact, when it comes to dementia, memory impairment isn't really the symptom that bothers people and their families. It's this. We call it BPSD, or behavioral and psychological symptoms of dementia. And it's everything from delusions and hallucinations to wandering to agitation, aggression. And people generally don't have just one of these symptoms. This is what this graph is showing. Anywhere from 2 to 5 is average for what people have to manage, and we really don't have good pharmacologic therapies, so we're always looking at ways of managing these behaviors, and one way we do it is we exert control through the built environment and try to manage them that way. And I'll sort of pose the bioethical question here. Do we think there's a difference between using medications to limit a symptom like wandering for people living with dementia and using architecture to induce a state to achieve the same end? So a common behavioral symptom in dementia, as I've said, is wandering. And we do this to try to prevent harm. We lock doors, we create alarms, we put barriers because we don't want someone in a memory unit to walk out and get hit by a bus. So we're well-intentioned, but this is what we've tried to do. So we, full-on barriers. We've done things like a trompe-l'oeil and concealed exits to try to prevent people from eloping or wandering. And we've done this as architects in classical architecture for aesthetic ends for years. And then sometimes this happens. So this is a geriatric hospital in San Francisco, and I want you to notice the floor pattern. You can see that it's alternating stripes. I believe this was probably a well-intentioned design decision early on in the design process for aesthetic reasons, probably. But if you ask any clinician on this unit, they'll tell you that the older adults here do not walk on this corridor. And you can see their doors are closed. And we just talked about the fact that immobility is extremely harmful in just a matter of hours. Why? Well, if you go to the literature, there are about 12 studies that look at this question. And what these researchers were trying to do is trying to prevent people from exiting. So they took an exit door, right? And they took some masking tape, and they placed a few strips of it in what I'm calling a horizontal striping pattern. And they found that once they did that, people actually didn't exit as much. They tried 98% of the time to exit before the stripes, and once the floor pattern was there, 42%. The really interesting thing is once they turned the stripes 90 degrees, everyone went out the door. Why? Well, in dementia, we know that there are visual perception changes. And we have changes in contrast sensitivity, color discrimination, depth perception. And so it's about understanding the brain changes and how that affects the interpretation of the environment. We think that this is being visually misperceived as a three-dimensional illusion, even though it's two-dimensional. So this may look like a staircase to someone with dementia, and they may not want to go up or down a staircase. I think one other point on that is we created a literature review where we took those 12 studies from the clinical databases and then published them in an architectural journal to be able to have architects and designers access that information. So there's great value, I think, to not only conducting primary research, but also bringing it together in review papers. So, design can't necessarily treat disease and illness, but it can certainly be a component of care, and it really should be. Evidence-based design practices have looked at dementia care facilities focused on autonomy as a design driver, and research has connected architecture with neuroscience. We know that areas of the brain affected in Alzheimer's overlap areas of the brain that deal with spatial navigation. So we use space design to try to combat confusion and disorientation in persons with dementia. This is De Hodgewijk, the original dementia village in the Netherlands. You can leave your apartment and wander down a street, go into a store, have a drink at the pub, get your hair done. But ultimately, this is a gated community, whether these people living there know it or not. And so it's come under some academic discussion in terms of the bioethics of this concept, and it's been likened to the Truman Show. And so a group of colleagues and I have tried to talk about these emerging ethical issues in long-term care that we're seeing. Design being increasingly used to modify behavior or create these illusions like the floor patterns without any research or oversight. So the illusion that someone's free to leave a village, but they really aren't. Immersive environments that convince people they're somewhere else or in a different time period, putting a 1950s car because we think that will placate someone who's agitated of that age group. Controlling behavior with designs that might evoke fear or immobility like the floor patterns. These efforts are really no different than what we're doing in medical and pharmaceutical research. And so how do we bring this all together in an applicable framework? How do we synthesize the data and the research? One way I think we can do this, and we should be doing this, is through a peer review process, which we do every day in clinical practice and in medical research. And so a group of colleagues and I are devising what we're calling a bioethics peer review to bring together clinical knowledge, evidence-based design and clinical planning, and also operations of facilities, and implement this at various stages during a design process. We've actually just recently been funded by the Greenwall Foundation in the United States to take this research to Washington, D.C., and meet with the Senate Special Committee on Aging. And so I'll ask this again. Is a further paradigm shift needed towards design quality measurement? And I would say yes, most definitely. We often have reservations about measuring design quality, but today all of our medical and surgical procedures are systematically measured before any kind of widespread implementation. So it scares me a little when we talk about standardized design and large rollouts of huge numbers of beds without maybe doing our homework and looking at the data. Medicine demands an evidence-first approach for sure. But there's really no regulatory structure that exists right now to consider the kinds of issues I've talked to you about tonight. Building designs, also keep in mind, impact those who are living there now, but also others, passers-by, families, visitors, future generations, and the future you. So anything we build today, many of us in this room are going to be in those hospitals, critical care units, and nursing homes in a few years' time. So I think it's time for architects, alongside clinicians and long-term care residents, to have a seat at the policy table. We need to advocate for long-term care designs and designs for aging that enable access, improve our health, and also enhance equity. I truly believe, and it's been my career's work, to focus on the fact that architecture has a critical role to play in designing for our aging society. And I think here I'm going to transition to my colleague, Stephen Verderber, to come up and talk to you a little bit more. Thank you.
Thank you, Dr. Anderson, for establishing tonight's core thesis. And I'm going to step back a bit and discuss some of the broader determinants that affect health equity among older persons, not only here in Canada, but around the world. The world is graying. By 2050, the global population aged 60 and older is projected to nearly double, from 12% to 22%, with many older persons at risk of becoming unhoused, experiencing mental health and neurological cognitive disorders, being plagued by alcohol and substance abuse problems combined with comorbidities, including diabetes, hearing loss, and osteoarthritis. Ageism is discrimination. Itself takes on many uncomplimentary expressions. Unhoused older persons. The number of unhoused older persons is increasing in North America and globally. It is impossible to know exactly how many older persons are unsheltered in Canada on any given night because there are no national statistics that break it down by age strata. Older persons with mental health disorders. Older persons are at greater risk of mental health disorders and associated health inequities, including chronic depression, anxiety disorders, delirium, and suicidal tendencies. The COVID-19 pandemic became superimposed upon prior decades of deep-rooted ageism in this respect, deplorable conditions for institutionalized older people in long-term care residential settings for people who had mental health disorders, being forced to occupy crowded bedrooms with insufficient personal distancing space or private hygiene facilities, often with 4 or more residents in a room. Older persons with cognitive deficits. Dementia is generally associated with later stages in life, with the risk of developing Alzheimer's disease increasing significantly. Currently, more than 55 million persons in the world suffer from some form of dementia, with over 60% living in low and middle income countries. With the proportion of afflicted older persons increasing each day, this number is expected to rise to 78 million by the year 2030 and to 139 million by 2050. Older persons and forced migration. Eco-catastrophe. Over a period of decades, Soviet authorities diverted rivers that flowed into the RLC in Uzbekistan to irrigate cotton and other crops in other locations. As a result, the world's fourth largest inland body of water, an area about 50% larger than Lake Michigan, gradually shrank, triggering an immense ecological and economic domino effect. By 2007, the RLC's surface area had shrunken by 90%, leaving the formerly waterfront city of Murnak a mere landscaped or landlocked way station for tourists to come and marvel at a newly created ecocide disaster zone in a doom loop free fall. Counter-therapeutic built environments contribute to health inequity among older persons. Heat, climate change, and elder mortality. Gaia Vince writes, "A great upheaval is coming. It will change us and our planet. Over the next 50 years, hotter temperatures combined with more intense humidity are set to make large swaths of the globe lethal for 3.5 billion. Fleeing the tropics, the coast, and formerly arable lands, huge populations will need to seek new homes. This migration has already begun. We have seen the streams of people fleeing drought-hit areas in Latin America, Africa, and Asia, where farming and other rural livelihoods have become impossible. Climate-driven change is adding to a massive migration already underway to the world's cities. The number of migrants has doubled globally over the past decade, and the issue of what to do about rapidly increasing populations of displaced people will only become more urgent. No place will be immune. With every degree of temperature increase, roughly 1 billion people are being pushed outside the global biological comfort zone in which humans lived for thousands of years. In the Anthropocene, vulnerable populations, and especially children and older persons, will require relocation to new, unfamiliar places. The world already experiences twice as many days where temperatures exceed 50 Celsius compared to only 30 years ago. Unmanaged retreat. Unplanned migration, whether within a country or across borders, is increasing. Just how many people will need to move in the coming years remains an open question and a matter of increasing urgency. As people in far northern and far southern regions migrate, where will they go? And will these places be able to receive them? And I think we're already beginning to see the fallout of unplanned forced migration or involuntary migration. Relocation and health inequity. It is daunting to leave where one has lived, perhaps for many decades, for an unknown, uncertain place, whether near or far. Geographic transitioning can seem insurmountable. Adequate architectural prosthetic support is critical on the receiving end. Its absence can bring severe consequence, even death. For older migrants and refugees, the two critical conditions are whether the move is voluntary or involuntary. And this is a critical point. And to elaborate on some of the research that Dr. Anderson cited, there's been a literature that goes back to the 1970s on the impact of involuntary relocation among older people moving from one nursing home to another. When there's a closure of a nursing home or it's being replaced, or if they have to leave temporarily, if the facility is being renovated and they have to move someplace and then return. In many of those studies, there was an unfortunately high incidence of mortality as a result of the move being unplanned from the resident standpoint. So a voluntary relocation involves the family and the resident agreeing to the move a priori, a process consisting of 3 phases: a pre-move anticipatory phase, the actual relocation itself, and settling in a post-adaptation phase. Involuntary relocation is where the resident is relocated against one's wishes or the family's wishes or both to an unfamiliar facility. It can be extremely stressful. Designing for the displaced older person. The United Nations currently estimates each year over 20 million persons, including over 5 million over the age of 65, are forced to leave their homes worldwide due to extreme weather events. Geographic displacement from place A to place B and possibly beyond, as we've seen in times of conflict, occurring even now in parts of the world, combined with the impacts of ecological degradation, is deeply rooted in cultural, political, economic, and health inequities. What exactly is an organized or managed retreat, and how does this phenomenon pertain to the forced relocation of older persons in the climate crisis? Infrastructural imperatives become extremely important. In this chart, which I don't expect you to be able to read, there are 6 primary categories of imperatives that can contribute to the well-being of older persons in a situation of a planned migration to a new place. You have social and cultural determinants, psychological and physiological determinants, political and public health policies that have an impact, economic concerns, climatic and ecological determinants, and the prosthetic support of the architectural and broader built environment. All of these function concurrently with much overlap and interdependency, and it's important for an architect to have a broader perspective such as this when making design decisions and advising clients on the best strategies for housing the elderly. And so, redundant queuing design strategies are one way to try to make a new environment or an existing environment more legible and therefore comprehensible to an older individual. Redundant queuing strategies start with public health policies that are needed to inform well-planned, properly funded, managed retreat initiatives, both voluntary or involuntary in nature, to help reduce adverse impacts to this particularly vulnerable population. And gerontologists often think of the elderly as you have the young elderly, the mid-elderly, and the old elderly. And so it's from 65 to 74 is the first group. The mid-elderly are 75 to 84, and the old elderly are 85 to 94. And now we have a 4th group, 95 and older, which needs to be carefully considered because they're equally subject and even more vulnerable than the other 3 groups of persons over the age of 65. The built environment strategies will require building redundant queuing directly into the landscapes and buildings inhabited by older persons post-move that are carefully keyed to the 5 sensory modalities, and in particular sight, sound, and kinesthetic experience. And this works to reinforce your presentation about even the hallway with the stripes. It's very, very poorly cued. And so you can redundant cue through sight, sound, a sign next to your door with the color of the door that might differ, or the Sunrise network of assisted living facilities in Europe and in North America have what's called memory boxes next to your door. So you can see pictures of your children or where you used to live, and these hopefully will function as cognitive triggers to help with spatial orientation in a residential setting. This is just one example. And the connection between the indoor and outdoor environment is also extremely important to provide spatial and cognitive orientation. Design considerations. Now, I was the recipient of a grant from the Ontario Association of Architects and Jacobs Corporation to look at design considerations for older persons in the context of COVID-19. And so this was funded in 2021, and the work was published in 2022 on the homepage of the Center for Design and Health Innovation here at Daniels. And this is the homepage and the link to the article, which I have a link here that I could actually take you to, but it would take too long. It would take at least probably a half hour to walk you through this report. But I would invite you to look at it because it has three components. It starts with 25 case studies from around the world of recently designed long-term care homes. It's followed by 50 design considerations that are based on evidence-based research. And the third section of this white paper is on, it's an annotated bibliography that has direct links to the source articles as PDFs, which is a rather innovative tool in and of itself. So the study is called Reimagining Long-Term Architecture in Post-Pandemic Ontario and Beyond. So I invite you to look at this, and all you have to do is just, in a search engine, just type in Center for Design and Health Innovation, and that's all you need to say, and it will come up the homepage of the center. So what about towards a prosthetic architecture for older persons? What can we do? What has been done? What still needs to be done, particularly in the context of the climate crisis? In figure 2 here on the upper right, it's the number of people living with dementia and the number of new cases of dementia per year in Canada, 2020 to 2050. This is published by the Alzheimer's Society of Canada. You can see how it's trending upwards so significantly. The bottom, which I might be in the way of here myself, the total projected new cases of dementia by type and region, 2020 to 2050 in Canada. And so you see all the different provinces and territories. And look at Ontario. It's stunning. The projected cases of Alzheimer's between 2020 and 2050. It's going to go to 3 million practically in Ontario, followed by Quebec and BC and Alberta, Saskatchewan, and then it trails off. So what are we going to do about this? Are architects prepared? Do we know where to find the evidence that the phenomenal amount of good evidence already exists to base design decisions upon? So I wanted to just talk about some of these design guidelines of the 50 and just briefly highlight a few of them. Here, there are 4 that are cited here. The titles. Their titles just provided. The importance of creating a village, an enclave, a sense of community. And then followed by the importance of prospect refuge affordances, opportunities to be public, opportunities to be private, and opportunities to be private while still looking at the larger social scene, like having a private window, a semi-private window seat when you could still look out onto a courtyard with activity outside. And for a staff person, the obvious example is a nurse on a memory care unit, for instance. They need a break. They need to be able to obtain refuge. So where their prospect is when they're in the unit, their refuge is when they can go take a break or go to a break room. And the same is true for the resident. The resident needs the opportunity for prospect and refuge. And so that particular guideline addresses this based upon evidence-based research from the last 2 decades, usually. Intergenerationality, combining children, their parents, and the grandparents together is hopefully going to become more common, rather than segregating older persons off to the side and at worst warehousing them. in poorly designed facilities that are on remote sites with poor linkages to public transit or where their family members live. Net zero strategies and ecological stewardship is self-evident in terms of this type of architecture, but that's applicable to all types of architecture at this point. But I think it's still worth calling out here in the context of older persons. The next set of 5 guidelines I'd like to call attention to in this report are the importance of medically safe bedrooms. Prior to COVID-19, communal bedrooms, bathrooms, and showers were regarded by infectious disease specialists as transmitters of communicable diseases. This became abundantly clear in the pandemic due to the disproportionately high mortality rates associated with these overcrowded conditions. Current best practices call for smaller, semi-autonomous houses comprised of all private bedrooms, 10 to 15 beds maximum per house, each bedroom with in-room private bath, shower. And the medical literature is beginning to clearly support this. And the popular media also. If you happen to have read the articles in the Toronto Star about what was going on during COVID in long-term care homes here in Ontario, and in particular here in the GTA, I found it really distressing. Personalization and distancing is another key guideline among these 50. Building codes and minimum facility design standards for nursing homes during the 1945 to 80 period were basically modeled on the standards that had governed the construction of hospitals. The dehumanizing atmosphere of hospital-based geriatric units in the 40s and 50s, housed within acute care hospitals, was exported into the post-war nursing home up into the 1970s. The kitchen and dining, there's been a significant amount of research just focused on kitchen and dining experiences among elderly persons in institutional settings. More choices are needed. Opportunities for intergenerational contact. And to help encourage activities of daily living among the elderly. Controlled wandering. Establish secure interior and exterior physical boundaries with locked doors, gates, and security systems without making them be institutional or visually oppressive or confining. And also perhaps incorporate activities such as horticultural therapy within the wandering garden or inside a winter garden, or have both, an exterior garden and an interior winter garden in a cold climate such as ours. And redundant queuing in these spaces will improve spatial navigation and legibility. Now, there is some debate about the single-loaded versus double-loaded corridor, which is optimal, but both can be made effective depending on their length. If a double-loaded corridor is employed, don't make it too long because then it's too much like a hospital or these old, outdated nursing homes from the 70s and 60s. Many of the best case studies that I was able to identify have single-loaded residential units, meaning that there's just rooms on one side of the hallway, and then when you enter into the circulation space, you can look out into a courtyard or some social, it could be an interior space like a sitting room or a day room, or it could be an outdoor courtyard. But it's getting away from the doors on both sides of the hallway for an oppressive length, which is one of the hallmarks of institutionality. As Hollywood tended to personify in films such as The Lost Weekend, which won the Academy Award in 1945, it was focused on a detox unit at Bellevue Hospital in New York. The film Shock Corridor from 1963, The Godfather from 1972, One Flew Over the Cuckoo's Nest from 1975, Flatliners. I can go on and on. I found about 60 to 70 films that focus on healthcare facilities, and I was able to develop a typology of them, and a striking number of them are the directors and the filmmakers want to hold us back. They don't want to talk about progressively designed healthcare architecture. They want to pull us back to talk about the cliches of excessive institutionality of the last century and even the 19th century. But we can't allow that to happen anymore. We need to be advocates for contemporary design and proactive, future-oriented design. Now, these here, which I'm about to end shortly with, biophilia and horticultural therapy. The literature states that there's a strong connection to the well-being of older persons. Ecological stewardship in terms of the design of the facility and its overall site. The importance of natural ventilation and daylighting in terms of maintain the natural circadian rhythms of the residents. And this concept of therasterialization, which is the connection between the interior and exterior environment in a way which is gradually layered, so that the wall, like the wall of this lecture hall, becomes dematerialized, almost as if it's not there. But yet it is there to separate from a climatological standpoint and maybe a safety and personal control standpoint. But visually and therapeutically, it becomes dematerialized. And this is one of the greatest challenges and opportunities for the architect who's designing in the realm of designing for older persons in particular, who have limited, perhaps, physical abilities, eyesight, hearing limitations, but yet if they can feel as if they're part of the world and not isolated in a box like we are tonight, that offers so much more therapeutic amenity for them that can actually lead to a longer life. And this is where we're headed, hopefully, with the architectural environment. Then there is the, in the next slide, which is my last slide, aging in place in extreme climates. I've worked with the Northwest Territories in Yellowknife and visited some of the long-term care homes there, and they just opened a new hospital in Yellowknife that I toured a couple years ago, and they're building long-term care facilities closer to the communities where the residents lived prior in their lives. For decades, the federal government would require that they might have to go hours away to move to a long-term care home, very far away from their village. And this model was completely rejected by the indigenous communities in the north, the far north. So we need to find ways to achieve aging in place in close to where the members of these communities lived for all of their lives without uprooting them in some sort of a forced involuntary relocation. And that's the second, or the third here, to avoid forced relocation whenever possible. And then the last two guidelines among these 50 that I would highlight with you now are destigmatize modular prefabrication. There is great potential with prefabricated off-site built architecture for older persons. It's just a matter of doing it. And there are governmental impediments, there are impediments within the construction industry, there are building code impediments, there might be NIMBYism from local communities who don't want, quote, prefab housing because maybe they associate it with a trailer community of some sort. But it's not like that. It doesn't have to be like that at all anymore. And then the importance of disaster preparation in the context of the climate crisis. Every healthcare organization should have an emergency preparedness plan ready for immediate implementation. I recall when I lived in New Orleans for 22 years. I lived there during Hurricane Katrina. My house flooded, yes. I had to leave for 3 months, didn't sleep in my own, neither did my family and I. We were relocated to Austin, Texas for 3 months, didn't sleep in my own bed, neither did my spouse or children. And it was an extremely unsettling experience that would have an impact on the rest of my career, actually, in terms of my trajectory, in terms of my research and practice activities. And there was a case of a nursing home in St. Bernard Parish where 40 residents in the long-term care home drowned when the flood walls broke in August of 2005. And all of the bus drivers who were scheduled beforehand to evacuate the residents all evacuated themselves. And so there was no one to relocate the residents, and so they drowned in their beds, essentially, and in their wheelchairs. And so I'm driven by that event, really. And it's now 19 years ago. So I just will leave you with that. And I welcome now Molly Chan to the stage. So thank you.
Thank you, Stephen. So good evening. My name is Molly, and I'm with the firm of NSDA Architects. We are a Vancouver-based firm primarily focused on work in BC. Over the years, we've had a number of opportunities to work on a fair number of long-term care facilities, and tonight I'm going to be showing you a few of our projects that hopefully reflect some of the principles that have been brought up by Dr. Anderson and Professor Verderber. The first project I'd like to talk about is Gateway Lodge. This is a project that was completed in 2009 and is located in Prince George, British Columbia. Prince George, for those of you who are not familiar with BC, is at the very center of the province, but this is still considered a northern community. The client for this project was Northern Health Authority, which is a local health authority for that region. They had requested a facility that would not feel institutional and to provide a residential environment that fostered social opportunities between the two lifestyles and to the community at large. Two lifestyles refers to the combination of both 81 assisted living and 94 complex care homes. This is what is known as a continuum of care. By providing housing for varying levels of care, it allows people requiring only a moderate level of assistance to move in, and as their health requirements increase, there's an option to move within the building to a complex care room rather than to relocate entirely to a different facility. As mentioned, relocation to a long-term care home is generally disruptive to people. Therefore, by minimizing the number of moves that people need to make as they age, the less disruption there will be to their social connections and to their daily routines. This model also provides the opportunity for married couples to remain in the same building rather than be separated as their health requirements change. I would imagine that if you had been with someone for 30, 40, 50 years, that you would want to remain together. However, our health system more often than not, doesn't allow for that. Gateway Lodge utilizes the decentralized model as the foundation for its design. This approach resulted in the creation of several households or homes comprised of a small grouping of 14 to 20 residents each. This would be similar to an extended family arrangement familiar in many cultures. Each home has its own dining, living, activity, and bathing areas and allows residents to live among familiar faces in a space which is scaled appropriately and not overwhelming. All the resident rooms in the complex care wings are intended for a single person. As mentioned before, during COVID, this became particularly important in preventing illness. The plan you see on the left is color-coded, with the blue indicating the resident rooms, the orange the administration spaces, and the mustard and beige areas indicating programmed and unprogrammed common areas. Assisted living households are located on the east side of the building, so the right side of the slide, while the complex care households are located on the west. The homes are configured and planned to create secured gardens and for maximum exposure to light, views, and fresh air. Gateway Lodge was designed with an aesthetic that respects the uniqueness of the northern region. The extensive use of wood reflects the city's primary industry, which is lumber. Building expression references traditional residential imagery that would be familiar to the inhabitants of this building and to the larger community. These references References include pitched roof lines, wood detailing, fireplaces, chimneys, things that you would normally find in homes that residents would have been relocating from. The use of familiar imagery helps to minimize the sense of displacement by making the facility feel more like a home and less like a hospital. Overall, this building has been pretty well received by staff and residents. In a community which is for the most part blue collar, this building feels both home-like and with a little bit of grandeur to help residents feel that they are being pampered and appreciated. The building is oriented in such a way to create secured exterior courtyards for the complex care households, as well as a more extensive outdoor walking path for the assisted living residents. This is indicated by the dashed red lines overlaid on the plan to the left. These walking paths provide opportunities for exercise as well as connection to green spaces. For the complex care gardens, the pathways are provided as a continuous loop to help people with Alzheimer's or dementia in finding their way back to their start point. Because this is a multi-story building, large patios are also provided on the upper floors so that those households also have access to outdoor space. And the last thing to mention here is that in a northern community where going outside is not always possible during the winter months, expansive windows were provided to give residents views to the exterior and daylight. This is particularly important during shorter winter days in a northern climate. In the interior, resident rooms are arranged around the perimeter of each household with support service rooms in a central core, allowing the corridor to form an internal wandering loop for Alzheimer's residents. Common spaces are located at the end of each block of resident rooms, allowing separation of private and semi-private spaces. Common areas are also designed as a separate but continuous space to allow multiple uses at the same time. While there are larger gathering spaces for the entire facility, providing varying scales of spaces gives residents options to suit their preferred activities. Sometimes it could be a larger group activity, or other times they might just be wanting to find a smaller corner or a quiet corner to visit with family and friends. Households can be physically separated from each other, which during COVID became particularly important in preventing spread of illness. The next project I'd like to talk about is Chorney Alzheimer's Center. The center's therapeutic goals follow the Eden principles of care, which is to seek to eliminate loneliness, boredom, and helplessness through tailored care and connection with nature. The building is situated on an 8-acre site in Surrey, which is a suburb of Vancouver. The center has 6 self-contained cottages with 12 residents per cottage, complete with a kitchen, living area, fireplaces, and recreational and dining areas. Once again, this project is planned using the decentralized household model. The cottages are arranged side by side with their main entrances off a north-south corridor. The corridor system connects the support and common areas of the facilities with the cottages. Building forms are intended to be simple and identifiable, alluding to the contextual language of the Cloverdale area in which it is located. For reference, Cloverdale has historically been a farming community, and a significant portion of the area in which it occupies is still agricultural. Similar to Gateway, references to traditional forms, materials, and scale of building help occupants comprehend their new surroundings and find comfort through familiar elements. Colors have been chosen to help with wayfinding and identification of parts of the facility. Households are again provided with a controlled wandering loop for walking and exercise, and these pathways are designed to allow continuous routes that lead past points of interest and activities. Each household cottage also has a covered exterior patio leading to the secured garden. These sheltered outdoor spaces allow residents to be outside in different weather conditions by providing shade from the sun or protection from the rain. Resident rooms are arranged around the perimeter of each household. However, in this project, the common spaces are in the center, whereas in Gateway, the common spaces were located at the end of each cluster of rooms. The wandering loop here is formed around the living, dining common areas. This arrangement eliminates the double-loaded corridor, which can oftentimes feel institutional. The difference between this building and Gateway Lodge was influenced by several conditions. The primary factor here being that Gateway had a higher number of residents per household, which necessitated a greater need of separation between the private and semi-private spaces. The slide to your right shows a memory box, which Stephen mentioned earlier. For Alzheimer's patients, we tend to incorporate memory boxes at the entrance to each resident's room. These are places for each resident to put personal items as a means of wayfinding by helping them identify their own room. It also allows others to learn a little bit about that person's life. VRS Group Home is a new house in the Kerrisdale neighborhood of Vancouver, providing accommodation for disabled residents with specialized care needs. Round-the-clock support services are provided by residential care aides who staff the licensed facility. While this isn't a care facility for seniors per se, this is still a form of long-term care that utilizes the same planning and design principles identified in the previous projects. I've included this project because it does offer an interesting alternative to the larger care homes. Where most of our projects take half a decade or more to get permitting and to be built, this one was very, very fast and actually quite inexpensive by comparison. The project was developed by Vancouver Resource Society, which is a nonprofit advocating for persons with disabilities. They have various funding models for their facilities, including partnership with condo developers and building their own around 50 to 100 unit rental buildings, which also includes support services for their clientele. Cost of construction for this project was less than $1 million, not including the land. Municipal process was less than a year, and the construction took just about a year. The design of the small-scale group home blends into the existing single-family neighborhood while providing accessible housing to people with disabilities in their community and helps to promote their independence. Despite a much reduced scale, the same ideas about access to outdoor space still applies. The rear yard with accessible planters, an accessory workshop building, and patio area are directly accessed from the living, dining, kitchen areas, similar to the arrangement you would find in a typical single-family home. There's one bedroom on the lower level facing the front yard, and on the upper level are the 4 remaining bedrooms accessed by the elevator. Handicap lifts are provided in each bedroom, as well as fully accessible bathrooms and the provision of wider hallways for wheelchair use. Even with these modifications, we have wall protection on the walls and kick plates on the doors. The place still feels residential, with large windows, wood floors, and a kitchen that pretty much looks like it belongs in a single-family home. As a side note, because the facility is staffed at all times, the kitchen was not designed to be accessible. The Village Langley is a 75-unit Alzheimer's and dementia care facility located in the township of Langley. Both Gateway and Chorney, presented earlier, both use the decentralized household model as a basis for their design. However, fast forward 10 years, and the concept has evolved to give us this project. The Village takes the same concept and expands on it both functionally and organizationally. The Village Langley is the first of its kind in Canada, modeled on a similar concept developed at Hogway in Amsterdam. The project takes the concept of the traditional care environment as close as possible to a familiar residential environment. In respecting the character and scale of the immediate neighborhood, the resident buildings are limited to 1.5 stories, and from the streetscape organized to look like a cluster of cottages. The cottages are located on a 7-acre landscape setting with a variety of paths, gardens, and outdoor spaces scaled to suit different activities. Functionally and organizationally, the project expands on the operational principles and the efficiencies of the decentralized household model, and expands from it architecturally through the design of the households, the exterior spaces, and their relationship to one another. The households are designed as a cluster of cottages that house common areas opening up to patios and gardens. 2 households of 12 and 13 residents each form a duplex, and there are a total of 3 duplexes on the site, along with a community building. Cottages face inward to form a secured walking path that resembles that of a neighborhood street with gardens, lampposts, gazebos, and other points of interest. Similar to the wandering loops from the first 2 projects, the path is designed for easy wayfinding, and the buildings are color-coded for residents to help residents find their own homes. The difference here is that a larger outdoor area shared between the households is being provided rather than the smaller household courtyards from the previous projects. There are still smaller outdoor areas interspersed throughout the complex for relief, but overall this helps to reduce the feeling of confinement for residents. At the entrance to the site, there is a community building that houses a multi-purpose area, cafe for gatherings, activity rooms, general store, and a barber shop, all of which the residents are free to visit as if they would go to the local town center. These spaces allow another level of normalcy to the person's daily routine, giving them an option to go to the barber shop or to meet with friends and family at the cafe. The community building is also open to the public to create a continuity to the surrounding neighborhood. Each household has its own living dining spaces, activity rooms, and TV rooms. The administration, staff areas, and service spaces are shared between the duplexes. And similar to the previous projects, common spaces are spatially linked, but are scaled so the residents can find spaces to suit their preferred activity and level of socialization. In the last 20 years, with the adoption of the decentralized household model, there's been a great improvement to the quality of life for residents in licensed care facilities in BC. The hope is that the Village Langley and the previous projects shown will allow for a holistic approach to seniors' care and long-term care as a whole. The spaces have been designed to provide an environment where residents can feel safe, engaged, and appreciated. Thank you.
So, is my mic back on? Yes? Okay, now we have the opportunity to have some bit of a discussion. Maybe they can amplify some of the points maybe we made in our presentations. And then just see if are there any questions from the audience? Mm-hmm. Do we have a way to get them a microphone? Okay.
Thank you so much to all of you speakers. I wanted to follow up on the last comment about opportunities for engagement. And I noticed that some of you identified opportunities for gardening, for farming, for socialization. And I think there was a very brief reference with the first speaker to music. And I just wanted to ask you about opportunities for sort of arts-based engagement. I've read really interesting work on drama and other forms of arts with kind of people who have various levels of dementia. And I was just wondering if any of you have anything to say about opportunities for arts-based engagement for the residents of these facilities.
I mean, on the sort of data academic level, you mentioned music. There's actually a very interesting paper that implements music therapy I think it was 3 times a week for maybe 20, 30 minutes, nothing major. And we actually saw cognitive improvement on pencil and paper testing to the same degree as when we gave medication, which was quite interesting. And there are very well-documented arts programs with persons living with dementia, mostly taking them out of the facility to museums and engaging with local arts partners. But I guess I think you've identified maybe a gap whereby maybe that should be brought into the facility. And I don't know, Molly, if some of your projects have considered that.
Well, I guess we are aware that some of the spaces that we've designed, so we do incorporate some multi-purpose areas in a lot of our facilities, and that's at the direct request of the operators. As part of that space, we typically are asked to put in sinks because they do intend to use them for some sort of arts and crafts programs that they would operate and run. I'm not sure we can get more specific than that because obviously it does come down to the people running the facility.
I would be interested to know how you take some of the design cues that you're doing for these specialized environments and move them down into the transition of people from homes when they're 60, 65 plus into, say, apartments, multifamily housing. You've talked about cues such as color, horticultural, so forth. So has any work been done on taking these cues that you're learning in these very specialized facilities and allowing those cues to be adapted so that people can live longer in apartments or in their condominiums going forward?
Aging in place.
Yeah, so I mean, that's a great question. I think, yes, I would say probably not as much on this continent. I think where I've seen that done maybe more extensively is overseas in Europe, and actually in Dublin is sort of the home base for the universal design sort of ideas and frameworks. And so actually online, I'm just trying to recall the name of the site, but there's actually freely available PDFs with great graphics to sort of teach people how you can adapt homes for aging and take some of these principles into the home. I don't think we do it as well in North America. There's not as much focus in our society, but certainly some of those, even I suppose the floor patterns and things can just be adapted to the home rather than institutional settings.
As a point to note, the BC building codes are actually changing early next year to mandate all multifamily buildings be 100% adaptable, meaning to provide, to future-proof all of these condominiums for aging in place.
Hello. So I align myself with the 2S LGBTQ plus group, and like most of the people out here have families, and the 2S LGBTQ community is the only community that's going to go into a situation where they don't have families once they get old. Now, I'm one of the facility managers at one of the 10 old age homes in the city, managed by the City of Toronto, also Leeds Green Associate. And there's lots of talk about resident care and, you know, how do we take care of people when they go into a facility, a care system. What I am seeing with the City of Toronto is most people that are there get displaced there because of unfortunate event. So right now, I'm working with OCAT students, 20 OCAT students and members of the LGBTQ community to form something called co-housing, which will be a very unique project for that's happening in Canada. But what I want to ask from an architectural point of view is why aren't we talking about how we can get people, because most people out here want to be in their homes or live very independent lives. Why aren't we moving into concepts where we can build communities where people are not pushed into a care-based system? And the second part of my question is, right now, this core group of 40 people are going to present on the 27th of November. How could this group, because we are going to influence policy advisors at different levels of the government, at the city level and at the level of the government of Ontario. What's happening in your group to influence out there so that we can get this change? Because I see a lot of people out here, and most people sitting out here, they have the capacity to live and thrive in society in a different environment. Why are we talking about resident care when there can be so many other models where people can thrive? Thank you.
That's on the theme of aging in place, in the home. It's a challenge. Where do you start and where do you end? When you go into someone's home and you ask them, what can we do for you to help make you more comfortable here so you can live here longer? My mother lived in her own home until she was 93, and she then resided 5 months in a long-term care facility, in a memory care unit in Chicago. And we did everything we possibly could to retrofit that home for her. And it was pretty remarkable that she stayed there as long as she did. And there are many people who don't have an environment that's as amenable. She was in a one-level ranch with minimal stairs. We locked the stairway down to the basement so she couldn't go downstairs, because that would certainly result in a fatal fall of some sort. And what about people who live in these homes in the East End that have these steep staircases with the only washroom on the second level? All these homes that were built in the neighborhood in the east of the Don, in the Danforth area and around here in the annex. How do you retrofit a home like that and allow them to stay? Even if you want to incorporate one of those chair lifts, I'm not sure those staircase widths can handle a chair lift in many cases. Is this what you're referring to in terms of retrofitting?
So my question was very specifically is, we are talking about when people go into homes, and I see the disaster that's happening in homes right now. I see it every day. So what are architects talking about to get people who are still in, we see the problem happening in 20 years, 10 years, 20 years from now. The tsunami has already started. So what are we doing to see that people who have not reached that level can live in society and contribute to society, but yet live in an intergenerational environment where they are not, worried about what's going to happen when they get old?
So I think there's a societal shift, right, to think about prevention of illness and an overall focus on wellness. And maybe to answer your question, we need to look at the younger generations or the middle-aged group. But as an example, social isolation and loneliness are huge drivers of health. We now know that from COVID. If you're socially isolated and lonely, this is quite detrimental and is even a risk factor for dementia to develop later. And it actually has quite a big link back to design of communities and design of buildings. And we can sort of spearhead loneliness and connections even through built space. And so maybe we need to think more as architects about some of these risk factors at different time periods over the lifetime, and how spaces where we even work, schools where we learn, and homes where we live with young families, how we can use that as a preventative tool to some of the issues we see with multi-complexity and aging and complex chronic conditions. But it's not a simple concept, I think.
No, it's very complicated. Oh, there are many questions here. In the front or on the side?
This is related to the previous speakers or questioner. This was touched in passing in a number of people, especially Stephen. I'd like you to focus more on where you're building versus the how you're building. And there is an opportunity to age in place that's probably acceptable enough to most of us. If I'm not looking forward, you're going to have to ask me kicking and screaming to go to one of these homes. Because I don't want to, and I would expect anybody here who's gray-haired and white-haired would feel the same. If, instead of trying to focus on how we can live in our individual homes, there is lots of space in schools, around schools. There's lots of land. If you built small-scale residences for seniors adjacent or over schools, there would be an opportunity to interact with younger generations. There's daycare centers in these schools. Mm-hmm. You could use the facilities after hours, the libraries, the computer rooms, the gym, and you'd be able to visit your neighbors or have your neighbors visit you. With the way families are scattered everywhere today, I have closer relationships with my neighbors than my family, and that's why I want to age in place. Mm-hmm. So I'm proposing that you look at models where you can build in conjunction with schools or any community space where there's lots of land.
There's a project right now underway in Detroit in a redeveloping neighborhood that had gone through significant decline in the area around the downtown core of Detroit, and it's rehabilitating a community public library, a historic library, which is on the National Register of Historic Places, and building housing adjacent to it, using the library as a nexus of community interaction and a symbiosis between intergenerationally. And that's one example I can think of. The incentives don't exist in Toronto for a developer to do anything like you're suggesting, however. We all know the situation here. They're biased towards building luxury condos, quote unquote, and who can afford those, particularly when not everybody, when they get up in years, is able to do this, to relocate to a high-rise luxury condo. Even so, and if they did, is it going to be designed to become a community the way you're describing? No. They tend to be isolated. And so it's going to require rethinking the urban design paradigm as well. It's not just about the building, it's about the urban context in the neighborhood. How do you rebuild neighborhood and build strong neighborhood intergenerational social fabric?
To speak to that, the first project that I did present did exactly what you're suggesting, and it is built right next to a high school, and the assisted living people are, because complex care is different, complex care, it's a different set of health requirements, but the assisted living people do have access to, to all of those facilities as well.
Yeah, I think that your points are well taken. I guess I wonder if the question shouldn't be directed to architects, so I don't know that you need to convince us of this. And I wonder if this has to come from a higher or policy provincial Ministry of Health level in order to create the change. I think as an architect, I've always felt that it's hard to make a change at our level with those designs. But yes, I hear what you're saying. Yeah. There's actually an interesting anecdote in San Diego with a hospice facility where they actually asked dying patients, we have 2 sites, we're going to build a new facility. We have one overlooking the beach and the ocean. we got this other site overlooking a canyon with some highways and cars. And it was just presumed that they would choose the beach, and nobody did. That they wanted that sort of connection back to movement and life and daily activity. So stakeholder inclusivity is very important as well in all of this.
Another aspect of, to respond to your question, is that there's this article from the Globe and Mail which pertains to your question. Facing mandatory upgrades, care homes opt to close instead. I don't know if some of you have seen this. It came out in last year. For-profit nursing homes in Canada's largest city are vacating the sector rather than undertaking mandatory upgrades, creating a property sell-off that hinders the Ontario government's promise of 60,000 new and upgraded long-term care beds by 2028. These homes, the problem stems from two colliding forces, the article goes on to say. Toronto's red-hot real estate market and a looming deadline for outdated homes to comply with design standards requiring single or double occupancy bedrooms. So there have been 9% of the long-term care beds in Toronto are disappearing right now as we speak because they've been sold to private developers who are going to tear down the long-term care residence and build a condo on the site. And so, and those older homes were in these well-established neighborhoods that were walkable, that had community amenities nearby, parks, good transit connections. The one that I'm most familiar with is Cedar Vale Terrace, which is about to be destroyed. It's on Walmer Place, just north of St. Clair. It's a tragedy to see that building go without any effort to try to, at least, if the site can be redeveloped, at least redevelop it in a mixed-use way, so that there may be a mix of condos and long-term care beds or assisted living beds on the site, rather than a hotel on the base and condos above, which is what they like to do. And so it's the community, the developer community has to come around too to see the value of retaining the quality of life in these neighborhoods in an intergenerational sense, in a more meaningful way than they are. So this Cedar Vale Terrace is going to be gone. It opened in 1974. Sure, it has a lot of problems, but is it beyond rehabilitation? I don't think so. I've toured it and looked at it very carefully. This is just one example of the many that are cited in these articles that are coming out in the paper. The Toronto Star is covering the story very closely also. The same story of disappearing long-term care beds in Toronto. Yes? Can you get the... Oh, I'm sorry. You can go next.
I just thank you very much for your talks. They're really interesting, and I've learned a lot. I'm interested in sort of the space that you all are working in between medicine and architecture and what it's like to inhabit that space, because it seemed like, you know, from Dr. Anderson's presentation, it's like you judge these architectural features by their impact on health, and you make suggestions, evidence-based suggestions for how to improve the architecture to improve people's lives. And from Molly Chan's presentation, we see these developments that fit into the neighborhood, they fit into the site, they're also beautiful, there's very aesthetic considerations. So I guess I'm just curious, what counts as success? Is it about impact on health that you can measure in medical terms? Is it about aesthetic qualities that you can, you know, make a case for in architectural terms? Or do those things always work together, or do you find yourself kind of sometimes in between a space where they don't coincide? Thank you.
Good question.
So Diana might have a different view, but we do try to reach back on occasion, you know, periodically to the projects that we work on, just to get feedback from the clients, from the staff who are using it, from the administrators who are running the project. And there are obviously lessons learned. We don't get it perfect. And I would hazard to say that we probably never will. But there's always that continuity of learning, that we build on every project with the lessons we've learned. That's our education in that case. Like Diana mentioned, there should be more quantitative ways of measuring success, but there's so many different factors. It's hard to isolate architecture versus the millions of other different factors that you would define success as.
Yeah, I guess sometimes I use the clinical lens, and so I really appreciate what you said about health outcomes, and it's making me think a little bit, and certainly with some of the studies that look at quality of life and other metrics, and sort of everything can kind of be quantified. We definitely can study the built environment. I think those studies are challenging, and they have to be set up properly. But I hear often, oh, you can't study buildings because you can't do a blinded trial or randomize, or there's too many confounders. But there are ways, I think, to set things up from a methods perspective where you could do well-grounded research. But I think one thing to maybe remember is, in terms of success, there's multiple user types. And we just have to ask them, but there's also staff, right? We haven't really touched on that as much tonight because these institutional settings have clinicians and other staff members, but their health and well-being is also very important, and what's successful to them may not mean success to a resident or a visitor. And then I think that's the challenge and the puzzle with architecture, that we try to satisfy all conditions, and I agree, we probably won't get things perfect, but the data is what can guide us, and I think, it guides practitioners in medicine, and it can guide architects. And it's very important to do what we call, I think, post-occupancy evaluations, but I hesitate. I don't know that we do them very well right now, but maybe another term, the peer review, or a way to measure at least different metrics, whether they're successful or not. One more. Okay.
So thank you, first of all three of you. It was really enriching to hear a lot of difference in what you focus on, and yet commonality of goal in terms of doing the best with what your success measures are. There was recently, just this weekend, André Picard, who's just released a book. He's a writer with the Globe and Mail, who brought to the foreground a number of issues. One of them was referenced by a previous question, that this data is very clear that people do not want to go into long-term care homes, to the point where there's a distinct percentage who clearly state that they would rather die than go into a long-term care home. So to use the terminology, the voluntary and involuntary displacement, it would seem that the structures that are being built are primarily for involuntary occupants. And so part of the dynamic is, of course, people. Picard, of course, has his own proposed solutions. He also tells our history of our healthcare system and our elder care system as originating, people literally were moved into prisons in some of the early facilities along the side of highways. So the institutional feel and texture and some of the images, it's almost like a familiar smell that evokes when you look at those images as institutional. So my curiosity from each of you is, how do you bridge that tension between environments that people are involuntarily being admitted to as a majority, obviously not all, and that those people are not traveling on their own? So the most extreme situation I've heard of was when my parents were aging in Nova Scotia, because the decisions are made provincially. People were getting divorced. People would be married for 50 years because one spouse could not get admission into care if there was another spouse at home. But what that highlights is that hopefully some of us are in relationships of whatever nature. There was a lovely reference to family cohabitating, but what is typical is that women live longer statistically. And statistically, there are many men in long-term care. Women at home are doing most of the care. Is there any consideration from a people perspective, from that involuntary transition, that considers moving people together? Because as the image suggests in that kitchen where people are having very high levels of assistance in that community, that circle with the caregivers, the people that are missing from those images, and I know this from visiting many people in care, are the hordes of family and friends that are providing additional care. Those who have substantial income hire personal support workers to go in and out. So there's a lot of traffic, which Picard pointed out in his study that the key factor in higher morbidity in senior homes in Ontario was not that people were old, but that in the private homes, the staffing model was piecework. So they had a lot more external people going into the facility, spreading the germs. So there are variables there that are people-based as opposed to, the housing, which worst case scenario is institutional in the prison model.
Well, your question's well taken, but it's largely a policy issue at that point. I don't think it's something, I think it's often something we're told, that this is the model, this is the policy when the facility is being planned. And is that your experience, that you're told by the client?
Can I just pause for a moment, though, because these are primarily students. You are our future. And so it's not to dead end with policy. We make policy. The baby boomers, particularly, have changed policy in so many different domains. So assuming that there's some leverage because our numbers are so high, it's, as Picard says, it's not a voting issue. Highways are, long-term care homes are not. But we can leverage that in conversation with people who are creating, as you are, viable, visible, testable, measurable choices.
I can add to that.
Could you?
Or just summarize
Could you?
what said. Having listened carefully, I think there is a horrible, there's a lack of connection between what we need as healthy seniors. A lot of us are in isolation, and that could lead to many diseases, and then the government policy. So we need to develop a connection between baby boomers, we're very vocal, and housing policy. A lobby group, the government is not in touch with all of us who are over 55 in this room. And architecture of health, to me, means maintaining our current wonderful health. And they are not addressing those who are in isolation, who could more easily develop disease. So there's a disconnection between our issues here today and government policy. What can be done to tweak government policy to address the larger, more serious issues of baby boomers?
That's right.
I mean, there's just so many dimensions to that question, thinking about how people end up in homes, hospitals play a big role. Can we target, that? That's a bigger topic. And then thinking about, again, talking to people. So so the dementia villages, I said to Molly before, I have mixed feelings, and my colleagues and I have written about the ethics around them, this whole idea of immersive environments. I spoke to some developers who even thought about doing things like magic mirrors and having reflections of people in their younger youth years so they wouldn't see their actual age. And sort of we're making these decisions as able-bodied younger adults for older adults without getting their consent. And so there's some suggestion in the academic literature that maybe we need an informed consent process, just like we ask people their goals of care. Do you want feeding tubes and breathing machines? Should we be asking them, do you want to be in a dementia village? Do you want a memory box, a wandering path? Is this something that fits your goals. I mean, I'm sort of using this as extreme examples, but this idea of informed consent and advanced directives for architecture have been suggested.
As a footnote to this, many of you know that almost 40,000 are on the waiting list to get in a long-term care home in Ontario alone. Almost 40,000. And is everybody on that list there involuntarily? Or would some prefer to be there because their home environment may have deteriorated for some reason? Maybe they don't have the social support. They live alone. Maybe they live in isolation. And maybe they would welcome the socialization quotient available in a residential community such as what was shown tonight. And in that regard, I think that this work, I've looked all across the country for state-of-the-art examples, and the work going on the West Coast and your firm's work stands out in so many ways as being some of the very best work occurring, not just in Canada, but even considering other parts of North America, in terms of trying to create a sense of village and a humane, personalized, humanizing environment for people when they do have to go to these places, whether they go there voluntarily or not. And so it's a difficult dimension, a challenge. And Ontario, we know that we're facing a crisis in Ontario right now. And it's only going to get worse before it gets better, unless the policies are modified to allow for more humane types of facilities to be built that are more welcoming and supportive.
Stephen, I just wanted to say something because I was listening to the last three comments. And I mean, one of the things that often strikes me about what architects are asked to do is to solve problems that we know how to solve. I mean, the issues are rarely a lack of architectural wisdom. They are really policy driven. And so speaking of what students need to understand is that they can't, tilt at windmills by saying that it's not a question. I mean, actually, I appreciate a lot the evidence-based research, Diana, that you're talking about. And I think that actually, as you're indicating, that it, in a sense, it arms you with information that can be used in what seems to me like a policy battle, even in terms of, from let's say, a government point of view, optimizing resources, and it could help you there. But I don't feel as if that we lack knowledge about what is good practice,
Right.
for the most part.
Best practices.
So it's misleading to indicate to students what they need to do is that they need to learn how to design better. I mean, they should learn to design well. But what they have to understand is the battle lies in the political arena, and that the fight has to be there. Otherwise, I mean, it's the same thing with housing more broadly. I mean, we know what good housing models are.
This is the mission of the OAA, especially since COVID, is to lobby the MPs to get the message across.
I guess I was just underlining the fact that, because I think the last question, the woman to my left, said something about the students in the room, and I just think, I don't know how many there are, but I mean, the message to them is that they have to be political activists and warriors.
Much more. Well said.
Okay, that was my. You have to also wrap up.
I think we are at the end of the time allotment that we have, unfortunately. And I do want to thank you, Diana and Molly, for being here. And I'd like to remind everyone about a few events that are coming up in the next weeks. The next one will take place tomorrow here in the main hall at 12:30 in the afternoon. It's a lecture by the Switzerland-based architect and academic Alfredo Thurman entitled Radio Activities, Architecture, and Broadcasting. And next week at 6:30 p.m. on Thursday the 24th, we will welcome Elizabeth Whitaker of Harvard University and Merge Architects, who will deliver the annual George Baird lecture entitled Housing Minimum Please. So we hope to see you all, and I want to thank you on behalf of everyone, and everyone who organized this event, Ali Caldwell and many others, for being here tonight. So thank you again.
Thank you.